Hello, everybody. Welcome to the March RDLA webinar. I'm going to give folks just a second to get logged on, and then we will get started. All right, let's go ahead and get things started. Again, thank you for joining the March RDLA webinar. Welcome to everyone who is here or watching the recording afterwards. If you have a question throughout today's webinar, please type your question into the Q&A box and a member of our team will direct your question to the speaker. And then just a reminder, if we do have any media joining us, we ask that you formally announce your participation and refrain from quoting any of the discussion during today's webinar. And instead, we encourage you to reach out to the participants after the webinar for direct quotes. We also have closed captioning available on today's webinar. In order to access this, all you need to do is click the live transcript button at the bottom of your window. And we also have Spanish translation services available. So if you're interested in using that, you can click the link posted in the chat and a live English-Spanish translation of the meeting will pop up for you. All right, so this is our agenda for today. Each of these speakers are joining to discuss bills on the federal level that their organizations are either leading or collaborating on. All of these bills are currently active in Congress and you can take action on them today. So we're excited to have you guys all here to learn a bit more. First, we have Sarah Chamberlain from Flock. After Sarah, we will hear from Kara Barassi from the Haystack Project. After Kara, we have Britta Dornan from NephCure. And then last but not least, we will be joined by Bailey McGowan from the Every Life Foundation for Rare Diseases. So Sarah, I will let you go ahead and get things kicked off.
Awesome. Thank you, Caitlin, and thank you to Every Life and RDLA for hosting this today. So I am from Flock, which was formerly National PKU News, just for a clarification. We now serve a whole class of conditions of protein metabolism, and I am here as a sort of member of the patients and providers for medical nutrition equity. So Flock, along with 40 other organizations, 40 plus organizations, are on that coalition supporting the Medical Nutrition Equity Act. And we can go to the next slide. So the Medical Nutrition Equity Act, the current House bill is 6892. It's the Medical Nutrition Equity Act of 2023. It has not been introduced in the Senate yet, but we hope it will be within the next month or two. So I'm just going to review sort of why we need the bill, what the status is, and again, how, as Caitlin mentioned, you can take action to support it. So we'll go to the next slide. So dozens of GI and metabolic conditions rely on medical nutrition as an important or sole treatment of those conditions. From my perspective, I work in the inborn errors of metabolism community, and metabolic foods, metabolic formula and low protein foods are what we call medical nutrition in our community. And for many of our, if not most of our community members, these are the essential baseline lifelong treatment for these conditions. My daughter has PKU. She gets on average 5 grams of protein from food per day and thus needs the medical nutrition to supplement the rest of the safe protein for her diet and calories and nutrients that she does not get from consuming food like unaffected individuals do. In terms of the GI community, I have a slide on sort of what conditions are under this bill, but there are things like Crohn's and colitis, short bowel syndrome, other allergies to proteins that require that individuals have these broken down formulas and medical foods in order to continue to survive and thrive. That was a long introduction, which maybe points to the fact that medical nutrition is hard to understand. It was defined by the Orphan Drug Act, sort of carved out into a special class because it is difficult to understand. But in doing so, it put us in a difficult position because it's in a separate category from drugs, and insurance payers and in general legislators understand, oh, you need a drug for your treatment, to treat your condition. Okay, we understand, we have a code for that. We understand the approval process. It makes sense. You pay your 20% copay and we're done. And that just doesn't happen with medical nutrition. And so part of what this bill will do is help better define that. State laws are inconsistent. A lot of laws cover medical formula, and in some cases, low protein medical foods for these conditions, but a lot of states don't. There are also exceptions based on condition. So PKU is rather universally covered, but other inborn errors of metabolism are not. Age, some states cover to age 5, age 17, age 25. Some only cover public insurance plans, while private insurance is not regulated. Gender, sometimes they cover women of childbearing age, but not men of that same age. And delivery method is an important one because often insurance plans will cover a formula if it is delivered by a G tube or an NG tube, but they will not cover that same exact product if taken orally. And obviously, exposing someone to a surgery to place a G tube just to get insurance coverage for these formulas is an excessive intervention. These formulas can run anywhere from $2,000 to $10,000 a month, depending on condition. And the costs of going without care, the health costs of going without care are incredibly high. If we look back at the formula crisis of 2022, the metabolic community was severely affected by that because they could not get access to their formulas. And so I like to say that now that we have the supply returning of those formulas, we actually still have a lot of people in crisis because they don't have the access to these formulas. Next slide. So the solution is the MNEA, the Medical Nutrition Equity Act. It's a federal law that makes coverage consistent, eliminates these loopholes based on specific exemptions, and makes sure that everyone has the essential coverage they need. There are a couple of questions. I talked about state laws that do provide coverage. With this law, sort of known as a federal floor law, states that already have coverage, their coverage won't be affected. It won't be reduced to the level of the federal floor. But states that don't have coverage, or individuals who don't have coverage because their plans are exempt from state regulations, will have that federal floor of basic coverage. This bill covers public, employer-provided, and marketplace plans, which is important. It's across the board, as it's written. Everyone gets the same amount of coverage. It's cost effective. It's not as though we're going to do an experiment to prove to Congress that not providing medical foods and having someone be institutionalized or severely disabled has a significant financial cost, but we can estimate that, knowing that if these individuals do not get their care in IEMs, there may be, health risks, including and leading up to death. In the GI conditions, there can be repeated hospitalizations, need for surgery, and other interventions that just don't make sense financially. Next slide. So who is covered? I talked about there are 4 classes, and this doesn't list all the disorders that are covered, but medical or surgical conditions of malabsorption, like short bowel syndrome. If someone had to have a bowel dissection and is not able to fully process nutrition, they can take one of these formulas that is already broken down, and it provides the nutrition and by a process that their body can absorb and process. Inborn errors of metabolism and conditions on the RUSP, the recommended uniform screening panel. Any of the conditions on the RUSP would be eligible for this if they required medical nutrition. There are some, as I mentioned, food protein allergies that are also covered, eosinophilic esophagitis and others. And then inflammatory or immune mediated conditions of the GI tract and the alimentary tract. All of those are covered, and there's language in the bill that leaves additional coverage up to the discretion of the Secretary of HHS, because while we want to prescribe the bill and make it as specific and limited as possible, we know that in the future, additional conditions may require medical nutrition, and so that's written in. Next slide. What is covered? Medical nutrition that is prescribed, ordered, and recommended by a physician or other healthcare professional. This is not gluten-free bread. This is, in general, not vitamins you can buy at the store, although there are a few vitamins that do fall under this if they are prescribed by a physician. It's for the partial or exclusive feeding of individual by means of oral intake or enteral feeding. Again, not specifying that they need a G-tube, but if they can take it orally, it will be covered. These are specially formulated and processed products. In the case of IEMs, you have low protein modified foods. It is foods that have specifically been engineered and modified to work with the low protein diet. And so it's not just something you can get off the shelf. It's for the dietary management of these specific disease or conditions. It's used under medical supervision, which may include a home setting. In a lot of cases, these are families feeding these low protein foods and formulas directly to either themselves, the affected individual, or to their children. So it doesn't require infusion or other things, but they are used under continuing medical supervision. And again, you have to be under the care of a clinic to have this, to have these interventions covered. Next slide. So how is it covered? One thing, some people receive these products from a pharmacy, others from a durable medical equipment company. This bill does not dictate that. And that's important because that would then have the DMEs and the pharmacies weighing in on, the particulars of the bill. And we want to say, get these people their treatment no matter how they can. With the amount of coverage, it's similar to mental health parity laws. It says if your insurance company pays 80%, then this has to pay 80% or an amount equal to 80% or the lesser of the actual charge for services. So making sure that it's not just sort of waving and saying we're covering, but only doing a small amount. It's making sure that a significant amount of this is covered so that individuals have access to care. Next slide. So currently, as I mentioned, the bill is in the House. Rep. James McGovern has been our champion for several Congresses now. And on the Democratic side, we have Representative John Rutherford of Florida, who just came on this session. Herrera Butler of Washington was our champion earlier, but when she lost her election, we were able to recruit Representative Rutherford. Both of these congressmen are very committed and energized about the bill, which is really important. In the Senate, Senator Robert Casey has been our longtime champion, continues to, really be taking charge of the bill. Right now, we do not have a Senate Republican. And for us, we often say, healthcare issues are not political issues. We need to make sure that they are bipartisan and that we are just making sure people have access to care. Senator Joni Ernst was previously the Republican Senate lead, but because the bill did not move last Congress, which I think we're all familiar with, there are slow processes. So many bills are introduced each Congress, and only 2%, I think, are passed each year. Senator Ernst really thought that we needed someone who was on committee to push this bill forward. So we are continuing to negotiate with several Republican senators to come on to the bill. I'm hopeful that will happen, as I said, in the next month or two, so we can get some acceleration on the bill here at the end of the last half of the year. Next slide. I think many of us who follow RDLA issues know that we end up introducing bills in multiple Congresses. It's not a one and done. We need to build momentum. We need to build progress. And so this bill this is the fourth congressional session where essentially the same text has been introduced and, had bipartisan, bicameral support, which again is incredibly important for this bill. A couple of things to highlight there in red. After the first introduction of the bill, the language for the bill was cut and pasted into TRICARE, which is the military insurance policy. And so individuals under TRICARE have had this coverage, since about 2018. It takes a while to implement, but that was a big success of the DoD recognizing the importance of this and gives us a little bit of precedence. In 2022, the federal employee health benefits coverage brought in coverage for formula for inborn errors of metabolism. So again, a small portion of this bill was incorporated into the federal employee health benefits, which is a pretty important precedent as we move forward. The next slide also, it doesn't. Okay, what's the holdup? We'll get to some other good things in a minute. What's the holdup? We're rare. As all of you on this call know, it's a small population. When we look at inborn errors of metabolism, there's less than 50,000 individuals who are really on these treatments and fall under this bill. And as I've gone through, it's a pretty difficult issue to understand. And so we need to continue to work, continuously educating our legislators and the public about why this is important. Frankly, the formula crisis actually did some good there, making people understand that, what's in these little cans is incredibly essential to sustaining life. That's why we work as a coalition. As I mentioned, 30, 45 organizations, including patients and providers, because we can't do this alone. And that's part of the message of RDLA as well, that if we all come together, we can really push these things forward. Mandates can be unpopular, particularly when they govern private insurance plans. We'll talk a little, I'll mention as we go and who we're focusing on. Particularly Republicans tend to shy away from mandates on private insurance. So that is a sticking point. The TRICARE precedent is pretty important there. The bill also touches a lot of committees in the Senate. There's the Health, Education, Labor, and Pensions. And then in the House, there's quite a number of committees because the legislation, again, interacts with interstate commerce and a few other things that make it just a little bit more complicated. Next slide. Progress has been made. I mentioned about these. We continue to get more co-sponsors, continue to have bicameral, bipartisan support in every Congress. TRICARE, when the Biden administration did the nutrition conference a year and a half ago, there was a mention of the importance of medical nutrition in that document that came out of there. So we're starting to gain some traction there. The federal health benefits coverage and a couple of hearings last year and even earlier this year. We had mentions of the bill as really an important goal to make sure that everyone was receiving baseline health care. And then in the last Congress, we finally got some technical assistance from CMS about the bill, which really improved it and made it stronger. Didn't substantially change it, but just is proof that CMS is paying attention to the bill and making sure that we can get a little more momentum on that. Next slide. The next steps, as we all know, everyone here we're the people who make the difference. You all telling your stories, sharing how medical nutrition is important to you or people you care about, people you know. You can share your stories. There's a URL on the next page, and also contact your legislators and ask them to support the bill. All of that information is on the next page. The website for the coalition is nutritionequity.org. You can reach out to info@nutritionequity.org, or I'll drop my email in the chat, sarah@flok.org, and I'm happy to answer questions. Thank you, Caitlin. And that's it. I want to leave time for the next people.
Amazing. Thank you so much, Sarah. We do have a quick question for you. Is there a reason that things like gluten-free bread wouldn't be covered under the Medical Nutrition Equity Act?
because we tried to make sure that the bill was as specific, focused on these conditions. When you start to bring in things like celiac, it's a much larger community and brings more significant cost to the bill. And so when we look at the likelihood of getting the bill passed, we needed to make sure that it was as narrow and specific as possible. That's not to say that I think this bill would probably set a precedent for other nutritional medical interventions. But I mentioned sort of 3 Congresses or 4 Congresses we've been in. There has been a bill going back, everything except, I believe, the 115th Congress has had a bill for the last 20 years for these medically required nutrition treatments. And so our goal was really to make the bill as streamlined as possible while providing that essential benefit. But I do think it would provide precedent, particularly now as the food as medicine, sort of movement picks up.
Great. Thank you so much, Sarah. And I did put the nutritionequity.org website in the chat. So if anyone's interested in learning more, feel free to check that out. Awesome. Thank you so much, Sarah. I'm going to go ahead and turn things over to Kara Barassi with the Haystack Project.
Awesome. Thank you so much. You can go ahead and go to the next slide. So Haystack Project is an umbrella organization of over 140 rare and ultra rare patient organizations. And I started with the Haystack Project as a volunteer nearly 4 years ago after my son was diagnosed with a rare congenital disorder. And since that time, advocacy, I'm sure like many on this call, has become a huge passion of mine. And I'm honored to speak with you today about this very important bill that will hopefully remove barriers to medication access for rare disease patients. Next slide, please. So you might be wondering why you are looking at a picture of a zoo aviary. Well, I thought this would be an easy way to illustrate the current landscape of getting medications covered by insurance. So when you go to the zoo and go to the aviary, first you have to walk through door number 1 where the gentleman is standing, and then you have to shut that door before then moving through the second door and into the exhibit itself. Next slide, please. So for the purposes of illustration here, if you think of medication coverage instead, think of the first door as medical necessity, and think of the second door as step therapy or prior authorization, etc. And you have to go through both doors before you can get approval for the medication. And by approval, I mean that your insurance company will pay for it. Now, the important thing here to recognize is that there are other bills in Congress right now that are focusing specifically on step therapies and prior authorizations. And those are important, but generally, they don't help all rare disease patients because we typically get stuck at that first door. So fixing the second door only helps people who aren't already stuck at the first one. So if we want those other bills to be even more helpful to rare disease patients, we need this bill first, because if we do not solve the problem of medical necessity at door number 1, we can't even start the conversation at door number 2. So now that we've established this concept, I'd love to talk more about why the Protect Rare Act is so important. Thanks, Caitlin. So first, I'd like to talk a little bit more about medical necessity, which I mentioned on that last slide. So these are 2 very simple words that allow your insurance company to not pay for the treatments that your doctors say you need. So these 2 very simple words have a lot of power. And the law or insurance company policies will allow insurance companies to define these 2 simple words to mean that they look at either the drug's label or a compendia, and if the doctor's reason for prescribing that medication is nowhere in either of those locations, they simply deny the payment. So insurance companies are not required to look anywhere beyond the label and compendia. And the huge problem for rare here is that rare disease treatments, as many of us know, are rarely on label or in compendia. So what does this result in? Well, payment is denied, and then begins the never-ending, time-consuming, and rarely successful appeals process. And this is so frustrating because despite our expert clinicians and our specialists prescribing us the medications that we need, insurance just hangs their hat on medical necessity and kind of throws their expertise out the window. So next slide, please. And this is where the Protect Rare Act will help. So this bill, in short, will require Medicare and Medicaid to look at other sources for what is medically necessary for rare disease patients. So if the reason that our doctors have a particular treatment they want to prescribe, if that is supported either by clinical guidelines or by 2 peer-reviewed journal articles, which frequently, that's exactly where we find guidance for rare diseases, then we can pass through the first door and move on to the next door. And in theory, this sounds really nice and wonderful, but you might be wondering, how are we going to get buy-in from policymakers to change this definition? Next slide, please. Well, in this case, we're actually not reinventing the wheel. There's a precedent. So cancer patients faced this same problem years ago, and Congress solved it for them. And they did this by expanding the definition of medical necessity for them also. So the Haystack Project then consulted with rare disease specialists, NIH, medical journals, insurers, the Hill offices, and even the leading compendia in cancer. And the proposed solution was to, once again, expand the definition of medical necessity for rare to not only include those on-label or in compendia guidelines, but also if they were in clinical guidelines or 2 peer-reviewed journal articles. So therefore, by expanding the definition, insurance companies can't continue to deny paying for these treatments that our doctors say we need, simply because it isn't on the label. Next slide, please. So as you know, a bill has to be passed in both the House of Representatives and in the Senate before it can become law. So I thought it would be good to give an update on each. So in the House, we have 4 great sponsors. They are all from the correct committees. We have 2 Republicans and 2 Democrats. And just like Sarah mentioned, healthcare is a bipartisan issue. We have support from all sides. The bill was part of the Health Subcommittee meeting on Rare Disease Day, and we are working to get scheduled for a markup next. Also, we have 18 additional co-sponsors so far, and they're all listed here. However, if you notice that your congressman or woman isn't one of them, please use the link here, and I'll make sure to pop all these links into the chat afterwards. Use this link to write to them. And I want to mention I have sent this to family members, to friends, to coworkers. It doesn't just have to be you as a patient or you as a caregiver. Anyone can tell their representative that they want to support this bill. The link is really simple. It's just a little bit of your information. And then we ask that you add a couple of sentences just to share your story and make it unique. And whether it's, hey, I have a friend who has a rare disease and they really need this, or whether it's you yourself. Any message, any personal message, especially going to the representatives, really makes a difference. Next slide, please. So in the Senate, the bill has to be reviewed by the Senate or by the Finance Committee. And we already have 2 Finance Republicans who are ready to introduce, and we need 1 Democrat. However, there seems to be a holdup from the chairman of the committee, and that is Senator Wyden. So if you live, work, or have doctors in the state of Oregon and want to help, please email me. I'll drop that in the chat later. We need more patients, caregivers, physicians to reach out and express how important this bill is to them. And if you're not exactly sure where to start or what to say, I am happy to help you draft an email or a script to call. So don't let that little bit of nervousness on not knowing exactly what to do prevent you from helping. Next slide, please. So in summary, many rare disease treatments are denied by insurers due to the lack of medical necessity. And the Protect Rare Act would help remove this barrier by expanding the definition of medical necessity for rare disease patients. Ultimately, this allows us to get through that door number one. There is already a precedent with cancer here, so we're just asking for rare disease to have the same. And there's no effort that's too small. Every bit of advocacy for this bill can make a difference. So again, if you can write to your congressman or woman, if you know someone or live in Oregon yourself and want to help, we also have a website for all things Protect Rare, our one pager, the bill language, a letter to colleagues, all different kinds of information is there. So even if you're just interested about learning more, I will provide that link in the chat afterwards. And of course, please email me directly if you have any questions regarding this bill. I would love to answer them, love to help. Of course, I can answer on the call, but happy to follow up afterwards as needed. Thank you all so much for your time today. Really appreciate it.
Great. Thank you so much, Kara. I see a question asking for your email, but I know you mentioned you were going to drop that and the link in the chat. So you're good to go on questions. Thank you guys. If you're interested in getting more involved here, keep an eye out in the chat for the link to send a message to your member of Congress as well as Kara's email. The message that they have drafted for you is super easy to send to your members of Congress. Doesn't take long at all. So I encourage you to check that out if this is a bill you're interested in. All right. And now I'm going to turn things over to Britta Dornan with NEFCure.
Hello, everyone. Thank you, Caitlin. It is great to be here, especially as a former Every Life RDLA team member and a rare disease patient with primary lymphedema. It's really great to be here. And today I'm here as Executive Director of Strategic Relations at NEFCure. And when you hear NEFCure, I want you to think two things. One is rare kidney disease, and the other is empowering patients, because that's what NEFCure is all about. The organization was founded 24 years ago, and our mission is to empower people with rare kidney disease. You can go to the next slide, please, Caitlin. And we work to empower patients to take charge of their health and to help lead this revolution that's happening in rare kidney disease research, treatment, and care. And so one way that we empower rare kidney disease patients is through the New Era Act. And so if you could go to the next slide, please, Caitlin. The New Era of Preventing End-Stage Kidney Disease Act is how we are working to make rare kidney disease voices heard. And this bill is championed by these two representatives. One is Gus Bilirakis from Florida, who should be very familiar to you as a good friend of the RDLA and co-chair of the Rare Disease Congressional Caucus. And our other champion is Representative Terry Sewell of Alabama, who has the highest, Alabama has the highest per capita number of citizens on dialysis. So by the bill's name, the New Era of Preventing End-Stage Kidney Disease, that's what it's all about. It's all about finding and treating the rare kidney diseases early, enhancing education of doctors and patients. And if this bill is put in place, it could really lessen the impact of these diseases on people's lives and reduce costs for patients and taxpayers. So before I get into a few slides on what the bill does specifically, let me just give a little piece on why it's so important. If you could go to the next slide, Caitlin. Let me introduce you to Marcelo. Marcelo is living with a rare kidney disease called FSGS. And patients like Marcelo spend hours every week hooked up to a dialysis machine that does the job of his kidneys. This is an example of what we are trying to prevent, because patients like Marcelo, they spend hours a week hooked up to these machines. They often have to stop work due to the toll that dialysis takes on their bodies. And even if they were to receive a transplant, which many rare kidney disease patients do, the kidneys are often attacked again by the disease, and the kidney fails again. So this is why it's important to understand the difference between what we call RKD, rare kidney disease, and chronic kidney disease, or CKD. You've probably heard of CKD, maybe in commercials on television. You know, if you have CKD, try such and such drug. Well, that CKD is often caused by diabetes and high blood pressure and other risk factors, while RKD is a group of conditions that affect the filtering units of the kidneys. And these diseases are caused by immune system dysfunctions and genetic mutations, and sometimes environmental factors, or a combination of those. And there are 150 types of rare kidney diseases, and they're much more aggressive than chronic kidney diseases. Up to 50% of RKD patients will progress to ESRD, or end-stage renal disease. And so to give perspective, people with RKD account for about only 5 to 10% of people with CKD, but constitute more than 25% of patients receiving kidney replacement therapy. And all of this contributes to $125 billion with a B a year that Medicare spends treating kidney failure. And it's why kidney disease is the 10th leading cause of death in the United States. And importantly, I want to point out, as you can see by looking at Marcelo, RKD impacts people of all ages. So that means that these patients could spend decades of their lives on dialysis. And it's also worth noting that RKD disproportionately affects Black Americans, who are 3.5 times more likely to develop end-stage renal disease. So like many rare diseases, I'm sure this sounds familiar to everyone listening, RKD often goes undiagnosed or misdiagnosed. It has few or no FDA-approved treatments. There's a small number of people who are affected. They don't know the causes often of the diseases, and we lack appropriate tests to monitor the diseases. Sound familiar? But we are in a what we call a new era because there is a wave of research going on. There's more than 40 clinical trials happening right now on RKD. And so that's why the bill is called the new era of preventing end-stage renal disease. So let's go to the next slide, Caitlin. Let me take you through just a few slides that show what's in the bill, because there is a lot in this bill. First of all, the bill would establish centers of excellence at the NIH, the National Institutes of Health, specifically for rare kidney disease. And why is that important? Well, because of what we just said in the previous slide, that rare kidney disease deserves and requires its own dedicated resources. And as you can see by this mother of an FSGS patient, Christine notes that care varies from state to state. It's a crapshoot what your care is going to look like. And so by creating these centers of excellence, they would focus on research and increasing public awareness so that we can get a better standard of care for RKD patients. Next slide, please, Caitlin. Secondly, the bill works to understand the RKD more and how to slow the progression of these diseases. It would require the Health and Human Services Department, the HHS, to conduct a study on these various elements. And I'll just point out here, we have Lisa Bonebrake, who many of you may know. She is the mother of a kidney disease patient and the head of the Alport Syndrome Foundation. And genetic testing is extremely critical for many patients with RKD, because like with Alport syndrome, if you were to not conduct genetic testing and just start throwing steroids at an Alport syndrome patient, which is a common treatment for kidney disease, that could be detrimental to the patient's life. And so that's why genetic testing is so important, to make sure that you get the right treatment to the right patient. So HHS would conduct a study and report back to Congress with recommendations. They would take a look at what is the impact of routine urinalysis look like? How effective are kidney biopsies? When and how should genetic testing be conducted? What does access to nephrologists look like? How does patient trust of providers contribute to access to testing and treatment? And so again, they would report back to Congress with recommendations within 18 months. Next slide, please. This bill also enhances provider education. Like with so many rare diseases, doctors don't diagnose them in a timely manner. And as you can see by Stuart Miller here, a rare kidney disease patient with IgAN, he saw 7 doctors before he was correctly diagnosed. And so this bill would provide grants for primary care training specifically on RKD, and would also establish nephrology fellowships specifically on RKD. And lastly, Caitlin, if you could go to the next slide. This bill also addresses how can we delay the need for dialysis and transplant. Once again, the HHS would be required to look at this and evaluate our current methods for treating RKD and report back to Congress with recommendations, because the situation is, as Kelly Helm here, who's also a mother of a RKD patient, she says the general public and even some medical professionals view dialysis and transplant as adequate treatments. Well, you can just go on dialysis or transplant, right? Problem solved. That's not acceptable. We deserve better. RKD patients and their families deserve better. So next slide, please, Caitlin. If any of this has resonated with you, I would invite you to please scan this QR code, and it will automatically generate a letter to go to your members of Congress. And you can add any personal note that you like, but you just fill out your name and address information and hit send, and we would greatly appreciate that support. We are looking to garner more co-sponsors for this House bill, and later this year get a Senate bill introduced. And if you would like to join us in person, if you enjoyed RDLA's Hill Day this past February, join us this summer in July for Rare Kidneys on the Hill Day. And you can go to nephcure.org to find out about that. Thank you so much, Caitlin.
Thank you, Britta. And I'll just say the same I did for the last one. The action alert that Britta has just mentioned, that you can access by scanning this QR code, is a very quick and easy, simple way to reach out to your members of Congress. Like Britta said, all you have to do is enter your name and your information so it can locate your member, and then it's pre-written and sends the message for you. So highly encourage you to utilize these different action alerts that have been talked about today. Great. I am going to pass things over to Bailey McGowan. Bailey is going to share some updates on the bills that were the official ask during Rare Disease Week. So Bailey, I'll turn things over to you.
Cool. Thanks, Caitlin. Hey, everyone. I will just be taking us through our Rare Disease Week asks, going through the bills a little bit and sort of where they've gone since Rare Disease Week. So to kick us off, I think our first legislative ask was the Accelerating Kids Access to Care Act, or HR 4758, Senate Bill 2372, and our sponsors for that were Representative Trahan and Senator Grassley. So as I think some folks on here know, if you are a member of your state's Medicaid program and you needed access to a provider in another state, that provider would then have to become part of your state's Medicaid program, and that can take a really long time. In some states, we're talking snail mail, so it can really be a process, and that's time that a lot of our patients don't have. So this bill will create a new, faster process where doctors can enroll in another state's Medicaid program through a federally streamlined screening process. It's totally voluntary to the providers, so no one's mandated to join this. But for providers who do, it would create an expedited pathway, and it would get patients to expert care a lot faster. Since Rare Disease Week, we've seen a jump in co-sponsorship by 19 in the House, Senate. So we're up to 81 co-sponsors in the House and 35 in the Senate, which I think is a really cool win. I actually saw one of the meetings that I jumped into to listen in on, join our co-sponsor list in the House. So it was really cool to see. Really like the power of you guys' asks and stories. If we go on to our next ask, which was the Safe Step Act, or HR 2630, Senate Bill 652 with co-sponsors Representative Winstrup and Senator Murkowski. This bill really addresses step therapy or fail first therapy, which is a practice used by a lot of health insurers or PBMs that force a patient to really try the preferred medication instead of the one being provided or prescribed by the expert care provider. In the rare disease community, that can cause a lot of irreversible damage through time. Sometimes the drugs aren't indicated for one another, and it undermines the provider's expert knowledge and care. So this bill would be a really huge win for the community. It would require that insurance plans, PBMs offer an expedient pathway for medically reasonable step therapy exemption, meaning that families would answer within 72 hours for emergencies and 24 hours for emergencies, instead of waiting a really long time to be told maybe yes, maybe no. Another cool piece of this legislation is that the bill requires the health plan to have a really transparent and readily available process for this step therapy exemption protocol. So no more really guessing around what needs to be provided and how many copies need to be there. It's all laid out really plain and square. Again, we've seen a nice little bump since Rare Disease Week Hill meetings, 12 in the House bringing us up to 176 and 1 in the Senate bringing us up to 38. So our third ask was the Interagency Coordinating Committee. This was modeled after a few coordinating committees we've seen for specific or therapy, not therapy, for disease-specific groups. But it's creating one cohesive space for all of the federal agencies who work on rare diseases to come together and make those decisions together, have those conversations in one room, instead of working in silos and then trying to, coordinate those decisions afterwards. Our request during Rare Disease Week was that this be included in report language. So our update is that EveryLife has been sending appropriations requests to all of our lovely House representatives and senators, and that our appropriations requests include language for this coordinating committee. And then I think I've got, a link on some slides with some more information on that. So if anyone has questions, I just popped that into the chat. So then our fourth legislative act was the Creating Hope Reauthorization Act of 2024, which was HR 7384. It was technically, our sponsor is Representative McCall, but it was also co-introduced with Representatives Achu, Belrad, Asparagan, and Burgess. So a really, I think, huge committee, group of people, and really good bipartisan support. Currently, we don't have a Senate companion for this bill, but we're hoping. But this bill would really reintroduce and reauthorize the Rare Pediatric Priority Review Voucher Program. This was established in 2012. It's authorized on a 5-year basis. But Rare Pediatric Priority Review Vouchers are issued to companies working on a qualifying drug for a rare pediatric condition. This voucher expedites the review pathway by about 4 months. So when the drug finally gets to FDA review, if a company uses it, it takes the review process from about 10 months to 6 months. So that's one really crucial way this can be used. The other way, which I think we've seen a decent amount of rare disease industry members use this voucher for, is you can sell it to another company and then they can use the voucher. So it doesn't necessarily have to be for a rare disease product at that point, but these vouchers are being sold for around $100 million. And for some of those smaller companies, this can be really crucial in keeping the lights on and keeping that progress going for the research and getting that therapy to market. It's really cool. We've seen 49 rare pediatric PRVs issued since its inception in 2012. I think the first one was issued in 2014. But this has gone on to help create drugs for communities like SMA, Rett syndrome, Duchenne muscular dystrophy, progeria syndrome, MPS, so many more. I think I saw one that was issued for the new MLD drug the other day. So they're continuing to use this pathway and it's really creating a difference. But unfortunately, we have to have this program reauthorized by September 30th of this year. Otherwise, the FDA will not be able to issue any more PRVs after September 30th in 2026. So far our co-sponsor update is we've had 18 since Rare Disease Week, which is a really cool jump, especially seeing as this bill was only introduced, I think 5 days before we got to the Hill. And it's, I definitely had meetings where they hadn't heard of this yet, so it was really cool to see sort of that jump in just the last month. And our last update, which is not necessarily on our official asks, but while we were all there, on Rare Disease Day itself, the House Energy and Commerce Subcommittee on Health held a hearing on the legislative proposals to support patients with rare diseases. They heard 18 bills related to rare diseases, including 2 of our own asks. So some of the bills you guys were there to work on were heard in committee the next day. This was the first step in this legislative process. So next up, any of these 18 bills can move forward to a subcommittee markup. They could go together, they could go separately, they could go as part of other packages. So we'll be keeping an eye to see what happens, but we've listed just a few of the bills that they heard that day. And I think that's all for me, Caitlin.
Great. Thank you, Bailey, for coming to share these updates. And all of those of you who are joining us today who took place at Rare Disease Week and took part in these meetings, congratulations to you. I want to give you all a pat on the back. As you can see, a lot of co-sponsors have been added to these bills, and that is a testament to the stories that you shared and the work that you did for these meetings. So a huge shout out to everyone who participated in meetings. I want to give you all a quick update on a RDLA program. Rare Advocacy Learning is one of our newer programs in RDLA. We are getting ready to get started on our 3rd annual Rare Advocacy Learning seminar series. This program is designed for experienced advocates who are really looking to take their advocacy to the next level. For each of the different series, we have a topic that we focus on. And for this series, we will be focused on patient-focused product development. This is going to be a 6-week seminar series, again, for advocates with prior advocacy experience. The course will take place April 23rd through June 7th. And applications to take part in this series will close next Monday on the 25th. So if you are interested in applying, I encourage you to check out the Rare Advocacy Learning page on our website. You can use this link on the bottom of the page here. This is a great opportunity not only to learn more about furthering your advocacy, but to network with other experienced advocates and those who are really active in the rare disease space. So if you have any questions about Rare Advocacy Learning, feel free to reach out to either myself or Shannon, and we are happy to answer any questions that you have. We also encourage you to save the date for our next webinar. Our next RDLA webinar is going to take place on April 25th. So we encourage you all to join us again. And then, of course, we encourage you to keep in touch with us between now and then. You can sign up for our newsletter, complete action alerts, and check out events that are coming up at rareadvocates.org. If you are someone who is just getting started in your advocacy journey or someone who's looking for ways to get more involved in the work RDLA is doing, I encourage you to sign up for the newsletter. It gets sent out monthly with federal and state policy updates, as well as free resources for the patient community and free events for the patient community. So it's a really great way to stay up to date with all of the things that are going on. And then, of course, follow us on social media if you do not already. We are active on Facebook, Twitter, Instagram, and LinkedIn. And this is where we post all of the updates for things going on within RDLA and the Every Life Foundation. And then, of course, if you have any questions about anything that was presented today, you're welcome to reach out to me. My email is listed here, klaws@everylifefoundation.org. And you're also welcome to reach out to our Senior Director of Advocacy, Shannon Von Felden, and her email address is listed there as well. So a huge thank you to our March RDLA webinar sponsors, and a huge thank you to all of the speakers who joined us today. thank you to each of you for coming and giving such a comprehensive overview of the different bills that you all are working on and ways that advocates can get involved to further these initiatives. So thank you all for your participation today, and we look forward to seeing you in April.